Welcome to the What If It's Not Depression podcast. I'm your host, Dr. Achina Stein, and we're going to be talking about brain waves. I have two wonderful people who are actually locally in Rhode Island, and we're going to talk about different ways to address brain dysfunction. I have Dr. Mark Turshin and Joshua Slepkow. We're going to learn a little bit about what they do and how potentially their services are for you. So Dr. Mark Turshin. Oh, and by the way, if you are really happy with this episode and like what you hear, please hit the subscribe button and the like button too. So Dr. Mark Turshin, he completed his medical residency at Brown University and has been practicing full scope family medicine at his private practice in Southern Rhode Island since 2015. In this practice, he has been able to work intimately with patients of all ages in an attempt to assist them in living their healthiest and most fulfilling lives. Through that lens, Dr. Turshin has seen some of the limitations of current treatment options for various mental health and neurologic conditions. Dr. Turshin has known the co-founder, Joshua Slepkow, for 2 decades. And after researching the helpful therapy that Joshua's son underwent, Dr. Turshin felt that he could further treat patients with this newer, cutting-edge technology. BrainWaves NRC is now the culmination of this goal. Joshua has spent the better part of the last 2 decades as a partner at a local Rhode Island law firm. And several years ago, Josh's son was diagnosed with an extremely rare genetic disorder. One of the components includes autism spectrum disorder. And Josh and his wife discovered MeRT technology, and their son received treatment at a brain treatment center location for 10 weeks. And with these positive results, Josh decided he could better serve his community locally in Rhode Island by transitioning careers and opening BrainWaves Neuro Restoration Center in Warwick, Rhode Island. Interestingly, Josh graduated Gettysburg College with a major in psychology. The founding of BrainWaves NRC allowed him to come full circle back to his original interest in mind. Welcome, Josh and Dr. Turshin.
Thank you so much. Yeah, thanks for having us.
Oh, it's my pleasure. We finally had dealt with all of these technology issues, and so here we are. I would love for us to have you talk about, your experiences with your son and how you came upon even discovering this new technology. And I seem to recall that the closest place was in New Jersey, but you felt going out to California was probably the best thing for the family, so that you could reside there for 10 weeks, so that your 10 to 12 weeks, so that your son could get that treatment, correct?
Yeah, that's correct. So as we've discussed, my son has a very rare genetic condition. So it's not a pure autism case, although all of the children with this genetic condition also have an autism diagnosis. And so in looking for some additional or alternative treatment methods, my wife discovered magnetic resonance therapy, or MERT, and that's obviously the treatment that we do here. And at the time, the closest, as you just mentioned, the closest location was in New Jersey. And treatment is every day during the course of treatment. And since you can't commute every day from Rhode Island to New Jersey, it kind of opened us up to wherever we'd be staying. So that's how we ended up out west, where I have some family. And that's actually where the company Wave Neuro, who has the patent for this technology, they're started in California. And so the majority of the locations that offer this treatment are on the West Coast. And as we talked before, we're the first and the only one located anywhere in New England.
Awesome. That's great. Well, tell us more about how this technology helped you and some of your other clients or patients that you see.
Yeah, I guess I'll take it from the non-medical side, but we began the treatment with our son, and one of the great things is with this technology, the treatment is it starts with an electroencephalogram, so you can see every patient's individual neuronal activity. So we saw that our son had kind of the typical brain pattern that you'd expect to see with other people with an autism diagnosis. And through the course of treatment, we began to see changes in him. And those changes were also shown on so there's the objective data in the EEG that shows his improvement, and then what my family noticed and changes in my son.
Awesome.
And we ended up doing 10 weeks because I didn't know when I'd be able to go back to California. Had I had a local one, I probably would have done maybe 6 or 8. But I thought maybe this was like a one-shot thing, and that's not typical. Most parents will bring their their children back on a regular basis, maybe once a year, approximately.
Awesome. Awesome. Yeah. So can you be more specific about what changes you noticed in your own son?
Sure. And so with autism being a spectrum disorder, the changes are going to be different from patient to patient. So the changes that I saw aren't necessarily the only changes that a potential patient would exhibit, but I saw a lot of increased awareness for him. He was always kind of like a little bit in his own little bubble and more aware of the world going around him, a little bit more of an appropriate emotional response. And then once he actually came around for a second course of treatment, we started to see some increase in verbalization. Now my son doesn't have a lot of stimming, but in a lot of other patients, we're seeing reduced stimming. So the kind of the response to treatment can be varied, and each individual is going to have improvement in different areas.
Mm-hmm. Great, great. So I know you probably use this word neuromodulation. It has come up. It would be great if you can, either of you could talk about what that is in a general sense, and then the different types of neuromodulation, and compare brainwaves to those types.
All right. He'll do the later, the more technical talking. I guess I've got the floor now. So neuromodulation is this growing area, which is basically kind of really boiled down is eliciting a response in the brain due to stimulation. And there, at the very top, it kind of breaks into invasive neuromodulation and non-invasive. So invasive is actually where they're implanting some device that's offering stimulation into the brain. We are not invasive. There's no scalpels, no needles anywhere in our office. So we're on the other side of that, of non-invasive stimulation. And the most common type of that, which has been around since the 80s, is called repetitive transcranial magnetic stimulation, or RTMS for short. And so that has been used since the 80s and have FDA clearance for certain conditions. And then what we offer here is a subset of RTMS called Magnetic E-Resonance Therapy. So we're using the same grade 2 medical equipment that's used in traditional RTMS setting, but we're also incorporating the use of a quantitative electroencephalogram, or QEEG. And so the QEEG is really kind of the underpinning of what we do here at MeRT, which is the use of the QEEG allows each patient to have a specifically tailored treatment protocol, and it allows to see objective changes in the improvements. So just to kind of differentiate that, in traditional RTMS, there's no EEG. So all patients, because there's no QEEG, the treatment protocols are not specific to each patient, they're generalized. And also there's no ways to specifically tailor or change the treatment protocol throughout the course of treatment, and to see any objective data in the EEG. So the combination of traditional RTMS with the EEG is what the company that we licensed the technology from, called Wave Neuro, they have a patent for that, and they've been offering this since 2009.
Yeah, awesome. Yeah, just so the audience knows, so TMS stands for Transcranial Magnetic Stimulation, right? And QEEG is Quantitative EEG. I think most people understand what an EEG is, but quantitative EEG is different. And so can you just describe what is being quantified, just so people understand what that means compared to a regular EEG?
Yeah, so the most, oftentimes what most people have heard of from an EEG perspective is when we're using it in a neurologic setting to diagnose seizure activity. So the procedure of doing the EEG here is the same, but the data is looked at a bit differently. And I'll go into some of the charts so it's a little easier, but we're looking at the data slightly differently than those folks. We still can detect seizure activity on patients if they are having that, but we're sort of quantifying that data differently than most typical EEGs are.
Yeah, so yeah, the great explanation. So, I know you mentioned, Josh, that what's different is the hertz that is used, and the way you get that information is through your technology, so that you are individualizing treatment for that individual. And how do you determine that? How do you determine, because the regular TMS is only one level, right? One level of treatment, and that's the same across the board for anyone who's getting TMS, right? Whereas your treatment is really personalized in terms of the data that you get. How does that come about? How do you realize that?
Okay, so yeah, so we it's really all based on the EEG. So again, typical TMS, every patient, and it's usually patients with depression, mostly because that's what insurance covers it for. So insurance covers typical TMS for depression, OCD, and migraines. Any diagnoses outside of that, insurance will not cover. So most of the folks who go through typical TMS have depression. So any patient who goes into a TMS clinic to get treatment will get treated in the same location, which is typically left frontotemporal location at the same frequency, no matter who they are. So there's just a standard frequency that has been tested mostly in some of the studies. So they all use that frequency. We have sort of a range of frequencies. And again, when I show the graphs, it'll be a little easier, but we're working in one specific frequency range, which is the alpha range from 8 to 13 hertz. And the frequency that each patient gets depends on their EEG. So not only does the first course of treatment depending, but every 2 weeks when we do a second and third and fourth EEG, we can tailor the treatment depending on how their brain is responding. So the frequency of each individual patient's treatment can also change during their treatment.
Awesome. Why don't we do that now? Look at the
Sure.
diagrams that you can share.
Yeah. So we're gonna look at a few. The first one I wanted to show is actually probably the most quote unquote normal or ideal one we get. So obviously there's some selection bias. We don't see a ton of people who are asymptomatic and have no concerns. So we don't see this is about as ideal as we've seen. So if you look at the chart here, we show 3 different graphs. So all of the data from an EEG goes to Wave Neuro. Their neuroscience team condenses it down to these graphs that are much easier to look at. There are 3 for the front part of the brain, the center part of the brain, and the posterior or the back part of the brain. And we do that with all of our patients, regardless of what they come in for, specifically because different parts of the brain are used for different things. So from a 10,000 foot view, the back part of the brain is where we take in information. So sight, sounds, verbal communication. As all that information gets propagated forward, the front part of the brain is much more important for things like cognition and memory and mood and speech. So we'll often see patterns based on specific diagnoses within the 3 charts. So if we look at the very bottom graph here, the posterior, the back part of the brain, the x-axis or the horizontal axis is the frequency. And we break down brain frequencies into 4 different types. So the slowest from 0 to 4 hertz are all the way on the left there. I think you can see my cursor, but all the way on the left here, from 0 to 4 hertz are called delta waves. And these are waves used predominantly when we're fast asleep. So if we did an EEG on somebody fast asleep, we'd expect to see a lot of delta wave activity. This next group from 4 to 8 hertz are called theta waves. And we'd see these predominantly in patients who are have just fallen asleep or who are awake but slightly groggy. They're a little slower than what is ideal. This next group, where there's this nice big spike in the middle, are called alpha waves from 8 to 13 hertz. And these are what we hope to see predominantly when patients are awake but their eyes are closed. And that is key, because whenever we're doing EEGs on patients, we hope they're awake and not falling asleep, but their eyes are closed as much as possible. And then everything over 13 hertz are called beta waves. And if the three of us were having an EEG right now, that's what we'd see predominantly. You're awake, your eyes are open, you're walking, talking, thinking, all of that good stuff. The y-axis is the amplitude, so the amount of time that you are using each frequency. So obviously, if we look at this patient's, the back part of their brain, they're awake, their eyes are closed, so they have very little delta activity, very little theta activity. One very big thin spike at a very specific alpha frequency, and then very little beta. So this person, while they're having an EEG, is almost exclusively using alpha wavelengths.
Got it.
And that's important because in all the technology and the studies that Wave Neuro has done, the sort of tenet of MERT is that it's disruption in this alpha wavelength, that disruption and asynchronization from back to front is often what causes pathology or what causes symptoms. So not only do we hope that patients are mostly using alpha, but we hope that the back, the center, and the front graphs all look fairly similar. And this is about as good as we've seen.
Okay.
Frankly, it looks better than mine. So, so this is what is quote unquote close to an ideal EEG.
Awesome.
Yeah, and just for reference, this person also was asymptomatic.
Correct.
This was just kind of a general screening, so that lines up.
Yeah.
Awesome. Awesome. Yeah, I don't like to use the word normal because
Right. No,
doesn't
no, and there's a lot of
necessarily mean
there's a lot of
well.
variance. Right, exactly. So let me okay. This so this is obviously several EEGs worth of data.
And I can disclose, this is mine.
Yeah, okay.
Yeah.
So so we do, as we said, we do an EEG before treatment starts. And then every 2 weeks during treatment, we do another EEG in case there are protocol changes that are needing to happen. So if we look at Josh's initial EEG here on the left.
I mean, I'm also, so I got this treatment, not kind of experimental, but once we opened this, I had suffered with depression for a decade and was taking medication for depression. And as we already discussed, depression was kind of one of the original uses or oldest uses for our TMS. So in the combination of opening our own clinic and that I've suffered with depression, I decided that I was going to move forward with treatment. And so, I'll give it back to Mike.
Yeah. So, I mean, from, again, 10,000-foot view, I think everybody who saw the last graph will see that this is not similar. So even if we look at the back, while Josh does have an alpha spike at a little over 10, maybe 10.5 hertz here, it's not overwhelmingly predominant like in the last case. And as we move forward into the front part of the brain, we actually see these slower theta waves take over as the predominant. So he is using sort of these slower theta waves. He is using alpha and some beta, but there's sort of a plethora of frequencies being used as opposed to one very specific alpha range. In general, patients with depression seem to have a predominantly slower wavelength. So whether it's slower alpha on the border here or even theta dominant. So this is consistent with other patients with mood disorders. And then you can see after 2 and 4 weeks of treatment, we get a nicer alpha spike, especially in the back by the time we're sort of at the end here. But even going forward, this graph now looks much more similar to that sort of quote unquote ideal patient we saw, where we do have this nice big alpha spike that continues going forward into the frontal range. And the only treatment done here was MERT, and Josh was able to get off medications because of this.
Awesome. Awesome. So did you notice a progressive improvement during the treatment, Josh?
I did. And, you know, I like to tell people about the treatment, and I know how self-serving it must sound, being one of the principals here. That what else am I going to say? Oh, of course it worked. But obviously I couldn't fake this what you're seeing on the screen here. And this obviously matches up with the improvements that I experienced. So within probably around the second week is when I really started to feel differently. My sleep was improving, which incidentally is one of the improvements that we pretty much see across all conditions that we treat. Autism, depression, other conditions, we see improvements in sleep. But for me, the thing that was most noticeable was mental clarity. Mm-hmm. And it just felt like I don't know, I kind of felt like I was always living in a fog, and then that was lifted. The other thing that I noticed is for years, I would have to take a midday nap, and I couldn't get throughout the day. Well, I haven't taken a nap really since I started treatment. I've stopped treatment. I did 6 weeks, and then I did another a couple weeks after that. But the improvements in mental clarity, the sleep, the reduction in naps, the focus, it's all really improved. And so with respect to coming off medication, we don't, and I may Mark can speak this better, but we don't tell patients to stop their medication when they start with us. They need to talk to their own physician about their medication plan. So after I stayed on my medication for a month, and then once determined that, that was seeing the improvements, then I started to come off the medication, and I haven't taken the medication. Now it's coming up on 11 months, and I've, really haven't felt this good since I can't remember when, but it's been decades.
That's great. That's awesome. Yeah. Did you want to show any other EEG, QEEG?
Yes. Yeah, I'll show one more since we've been talking about our autism patients, which is the majority of patients we've seen so far since we've opened are kids with autism. So again, if we look at this very first one from April, this was a 6-year-old patient before treatment who has a fairly typical pattern of autism where, especially in the back, we usually do see some sort of alpha activity. But as we get to the front, and this is actually even a better one than some of ours, but as we get to the front, we typically see mostly theta. This patient has a spike here, so he does have some alpha activity. Sometimes we'll see, if you can see my cursor, just sort of a straight line down. And so these patients with autism tend to be using that slower theta wave exclusively and almost totally, especially in the front part of the brain. And again, front part of the brain being most important for cognition and mood and speech and those sorts of things. Mm-hmm. So this patient, again, after 2, 4, 6 weeks, has a much more, and this was one of our better outcomes from an EEG perspective. Autism can tend to have slower response in terms of EEG changes, or especially in the front. But this patient obviously got a huge bump in alpha activity in the back, which carries forward. He's still using theta, a little bit here in the front, but nowhere near what he was initially. And again, since we're so focused on alpha activity and trying to get these kids to use this faster speed in the front, we're always hoping to see a lot more alpha activity once patients have gone through treatment.
Awesome. So this looks like to be about 10 weeks out of treatment. What did you say, 3-4 times a week?
So he did. So this patient did 6 weeks. It looks like that just because they didn't start immediately after that first EEG. So a lot of kids are coming from an EEG and a month later start. So this was 6 weeks total of treatment. So you mentioned frequency. One of the barriers to treatment for some folks is that it is every day. So it's Monday through Friday. We book for about an hour. Patients are in the seat getting treatment for about 40 to 45 minutes, but it is coming into the office every day, Monday through Friday, for those 4, 6, 8 weeks, depending on the patient and what they're here for and what we're treating for.
Mm-hmm. And one other thing I don't know if this was mentioned, but the EEG report always shows your first EEG, your last EEG, and your second to last. So any EEGs prior to the second to last get bumped out of the report. So in this patient's case, there was another EEG prior to June 30th, but that gets bumped out because it shows first, last, and second to last.
Got it. Got it. Yeah. So it's, I think I recall you telling me that you have a EEG done on the Fridays before the treatment continues. Is that right?
Yeah, so the normal course is a patient comes in for their initial EEG, then that data gets sent to the lab at Wave Neuro. They produce this report, and then Dr. Tertian will meet with the patient to talk about treatment and decide if they want to move forward with treatment. Once a patient begins treatment, the normal course is treatment on Monday to Friday, and then treatment on Monday to Thursday of the second week. And then on that second Friday, or on the 10th day that you're with us, you have a follow-up EEG. And then you'll continue right in the next week with that same schedule. And then you'll have a meeting with Dr. Tertian to review the results of the EEG and talk about your own subjective impressions from the 2 weeks prior. And then at that time, you just decide if you're going to move forward with another 2 weeks. So patients aren't just determining how long they're going to do treatment at the outset. That determination is made every 2 weeks, whether they're going to continue with treatment.
Mm-hmm. Great, great. So what percentage of, could you talk about the diagnoses that you treat other than autism spectrum disorder?
Yeah, so we can and do treat the typical diagnoses that folks go to TMS for. So depression, OCD, migraines. We've actually had a few patients who have done treatment for headaches or migraines that have gotten really good benefits from. We've already mentioned autism, and then diagnoses like PTSD, traumatic brain injury, anxiety. There's more data coming out about more neurodegenerative type diseases in older folks like Parkinson's and Alzheimer's disease. The protocols might change a little bit in terms of how frequently those folks have to come, but they're starting to see some good benefit for those too.
There's also a recent study on the benefit for long COVID brain fog. Now, obviously, with that being so recent and takes a while for a study, I think there might only be one study, but that's just kind of because it's so new, but showing the benefit for that as well.
Yeah, and even in that study, they looked at it at some of the EEG data, and a lot of it is somewhat similar to what we're seeing in the folks with long COVID who specifically have fatigue and brain fog type symptoms. They're seeing a lot more theta activity in those folks that then reverts to or progresses to alpha activity with treatment. So it's a similar sort of pattern that we're seeing in some of the other disorders.
Mm-hmm. So I'm curious, for those people who have FDA approved diagnoses for billing, are you billing on their behalf? Are you able to for the depression?
No, so we're private pay. So if a patient does have one of the conditions that could have insurance coverage, we will help that patient provide super bills and provide the documentation they need to either come to see treatment and then submit to their insurance company, or if they want to seek pre-approval prior to beginning treatment, providing the documentation for that. But we're not billing directly to insurance company, with one exception. We are in network with TRICARE, which is for the veteran insurance company. So.
Great.
Yeah, so any vets that are coming, we can bill directly to TRICARE. Outside of that, it's private pay to us, though patients can get reimbursed if they have one of those specific diagnoses.
Great. That's awesome news. That's really wonderful. Yeah, I'm curious if you find that people who have had TMS in other places where it's not QEEG guided, if they are finding that this method of using TMS is you're seeing better outcomes.
That's a good question. I don't know that we know that. I mean, but one of the issues is two things, I guess. From a TMS perspective, tracking outcomes is really only subjective, which I think is a little limiting. I mean, we definitely use subjective improvements from patients as a key to drive whether patients should continue, but TMS has no objective data to show that there's any change in the brain activity. So it'd be a little hard to balance. I will say there's definite decrease in side effects profile from our perspective again, TMS is treating in sort of a one size fits all. So not only does everybody get the same frequency, but the sort of intensity of the treatment is higher than we ever treat. We have specific protocols based on patients' diagnoses and if they have limiting factors. So some of the side effects, which most common are headaches and some sleep disturbance, seem to happen more in TMS than they do with MeRT.
Mm-hmm.
I will say we haven't had any patients who have done TMS previously who have then come to us for MeRT, so I don't have direct comparison.
Okay, yeah, be interesting to gather that data and compare, right? At least from a subjective standpoint, better, same, or worse.
I mean, you could see, and I sort of keep harping on this individualized protocol. You could see that range of alpha that we're targeting is 8 to 13 hertz. So if TMS is always treating at, let's call it 11.5 hertz, some people's brain innately will not be using that frequency. Their innate frequency might be 9. So you're sort of, while you're treating in that alpha range, you're not treating to their specific frequency. So it would be interesting, but to see, I don't know that they'd ever do a study to show that, but I imagine there's something to individualizing that protocol.
Yeah. I mean, there might be some data you might want to try gathering, put it on your intake. Have you ever had TMS before, right?
Yeah.
And to look at the results and compare. That would be really great study to do, because it makes sense that if you are gathering that information for that individual, that they would respond at a specific hertz, of treatment, right? It just makes logical sense to me.
Yep.
So what else can you tell us about TMS and neuromodulation that we haven't discussed, so that the audience better understands, what are some of the things that have come up with some of your patients that would be interesting things to know about your practice?
Yes, I think a couple of things. One, just because I mentioned side effects, we should say that the two most common that we see are headaches and sleep disturbance. So just so people are aware, the headache's usually a sort of tension-like headache, typically resolves after the first couple of days, but usually resolves with Tylenol or Motrin during those days. We haven't had patients who have headaches really beyond the first couple of days of treatment. And sleep disturbance, while many people, if their sleep is an issue, insomnia specifically, have improved sleep with treatment, sometimes, especially the first couple of days of treatment, it's like your brain's getting a workout. So a lot of people will feel euphoria after an actual workout. So some people will feel energized after treatment. So especially if they're getting treated later in the day, sleep initiation could be a little difficult. So if that's the case, we'll sometimes just change timing of treatment for patients. But again, usually not something that's long lasting if patients are going through 4, 6, 8 weeks of treatment.
Right.
The other thing I'd say is we work in these 2-week cycles, A, to update the protocol, and B, to make sure that patients are getting benefit and it's quote unquote worth continuing with treatment. If we have somebody do that first 2 weeks and the EEG looks exactly the same and they are feeling or seeing no subjective benefit, then we sort of talk about realistic expectations. There are going to be 10 to 20% of patients that do not respond. And, I don't want people wasting time and money for 6 to 8 weeks chasing a treatment that might not be helpful. For those who have any subjective or objective improvements for 2 weeks, that's when we continue and do 2 more week courses. I'd say the average patient does somewhere between 6 and 8 weeks, depending on what they're coming for.
And are there any contraindications? Who is this not for?
Yeah, so there are several, usually to do with like medical device implants, so shunts or stents or pacemakers, pregnancy. We have a few that are risk factors and might just make our protocol change, things like bipolar disorder and schizophrenia. But we have a whole list that people look at for certain medical conditions or certain device implants that you would not be able to do with us.
Okay, that makes sense.
One thing I wanted to add, I don't think we touched base, and it's a common question I get, is kind of how long we talked about it. It's every day, but haven't talked about how long does it take. So the appointments we book are 45-minute intervals, but the treatment takes less than that. It's usually 30 to 37 minutes. And so we know it's a huge time commitment to come to our office every day. We can't do anything about how often you have to come here, but the only thing we can do is make sure you're not like the typical doctor's office, no offense, where you have to sit in, well, his practice is not like that, but you have to, you know, you go to the doctor's office and you sit there for 20 minutes before your appointment. So we make sure all our patients walk in, they basically walk back to the chair and they walk out. Just so kind of it's as little disruption to their day as possible. And then one other thing that we didn't touch base on is kind of what does it feel like? People want to know, you know, is this painful or are they in some big contraption? And they think of it and they often want to know, is this similar, you know, is this shock therapy, which it's definitely not. So patients come in, they sit in a very nice recliner we have. There's a rubber paddle that goes up next to their head. They're not inside any equipment, and it gets placed against their head. And then the sensation is that of a pen tapping on your head. So, you know, you imagine flicking a pen and you're tapping against your head. So it's definitely not painful. It's not pleasant, but it's probably best described as annoying at worst. And, you know, some people find it a little annoying, but some people really enjoy the sensation. And I can tell you, I fell asleep once during treatment, so it couldn't be that. It's not that obviously painful or aggravating.
Right. Well, I did come for an EEG, and you know, and you put this whole contraption on my head, and that does take a good 5 minutes, I think, to have it all set up. So yeah, but it's pretty you know, it's really fascinating. The whole process is fascinating. So I'm really glad that I was able to get that baseline EEG with you guys, and it was fascinating to learn the results as well. I certainly could use improvements. It's not optimal. I'm sure everybody could on some level. So, yeah. So tell us where you're located and how people can reach out to you. What's the ways to contact your business?
So we are located in Warwick, Rhode Island, in the Warwick Medical Building, 400 Bald Hill Road, and you can find us online. Our website address, Facebook, and Instagram, they're all the same. It's BrainWaves NRC, so that's as the first letters for Neuro Restoration Center. So BrainWavesNRC.com or BrainWaves NRC on Facebook and Instagram.
Great. And then I appreciate you offering a 50% off of the EEG for listeners. It's normally $350, but it's discounted price to $175 for those who mention my podcast. I think we covered a lot. So nice. I really appreciate all your time in introducing something that's going to be really helpful for a lot of people. I'm glad you're getting some good results with people, especially if many things have been tried, and it sounds like you obviously, people find you because they're looking for alternatives, and they've struck out in the conventional world and used whatever's offered to them in the standard way, and they're just keep searching for other options. And so thank you for being there and having that option available for people to resource. So thank you. And if there's any last words, now's the time.
Thanks for having us, and happy holidays and Happy New Year.
Yeah, thanks so much for letting us chat about this.